Discussion. We'll move on to the next speaker, Dr. P. PANNEER SELVAM, who will be speaking on enhancing surgical prowess through camp activities, the schedule, and the need.
Good afternoon. Thanks, AIOC, for the invitation. What you measure is what you get. So this is what I measure my surgical training program. At the end of the course, the candidate should do independently. But at what cost? There should not be any compromise on patient safety and quality. Just because they are operating on a camp patient or a charity route, we cannot take it for granted. With this in mind, I set a SMART goal. Specific, measurable, attainable, realistic, and time-bound. So how to proceed? So how to run a SMART program? This is our program, usually for 15 days, 10 operating days, Monday, Tuesday, Thursday, Friday. It's a standardized teaching and only basic technique, 4-quarter, period. The whole purpose of this 10-day program for them is they should understand the concept. And the attention is given to the motor skill, hand-leg coordination. And this 4-quadrant technique really helps us. And it is not from start to finish. We start non-linear. We usually start with the phaco part. We do the section, we do the rexis, hydro dissection, initial trenching, and we ask them to do. So first is understanding, coordination, the microscope, like what you said, how they view it. All these things are corrected, and this 4-quadrant technique gives us the time, and we can always intervene. And basic thing in 15 days, we don't know their background, they should develop the sensitivity to the ocular tissue. That many of them, they will be rough handling. And the program is concentrating mainly on how to avoid complications. There are more don'ts rather than do's. So finally, at the end of this 15 days, they develop that inner confidence that they can do this surgery or they cannot. So based on that, they can extend it or they can proceed it. We are not making them expert, but we are making them aware. This is what the surgery is all about. So method. So in 4-quadrant, this is what we do. Ask them correct way of holding and make them realize it is not the hand that is doing surgery, it is the leg that is doing surgery. How much pressure that you should use, how much power should be there. And in this, we teach them the coordination of left hand movement, how to place this left hand and how to do it. The position is very important. Next is climax. Make them experience phaco or whatever it is. So how do it? This is the most part, everybody is worried and a lot of intervention happening. So we make them do it, slow down and make them do that handling. Keep it straight, horizontal. Let the tip or the nucleus piece come to you. So this teaching comes, they understand this is what is happening. Typically make them slow down so that they can really feel this is what phaco is all about. So in that way, they are able to understand it better. Complication, any training program. We cannot shy away from complication and we have to measure it. In our case, it is 5 to 7%, but we have a management protocol. Complication cannot be avoided, but if the complication happen, and remember, in a camp surgery, it's a high volume. It's an assembly line production. And one person stops and the whole system goes out. So what we learned is, if there is a PC rent, stop then and there, come out. There is no point injecting viscoelastic, calling the senior. If it is fair, and the sisters are trained in that. So once that happens, we do it later. On a Saturday, the tinkering work starts. We evaluate the patient, we see that he is quiet, then we do the secondary IOL. So in that way, they understand how the complications are not on the table. That really disturb the whole process. And we also have mapped out where the complications happen. So that way, usually in SICS, cortical aspiration is a major point. In phaco, the same thing. And the last piece. These are the areas where we give more attention and people really. And in spite of all these things, we cannot be present. We should have a communication or information coming to the theater. Everything is going well. Because we see people from different background and they have different ambition or innovative style, but it should be approachable to the or standardized. So what are the requirements in running a program like that? You should have a proper infrastructure. And there should be a constant stream of patient availability. And there should be a trained trainer. And there should be enough time for the fellow to understand the surgery. And ultimately, they should have a passion. You should really be willing to teach. It is a back-breaking job. So it's not that easy that you have a constant stream of, you have high volume camp patient, you can run the program. Unless we are really interested in teaching, this program cannot be successful. So the ecosystem, trainer, trainee, and the patient, you should not forget. So what are the qualities of a trainer? Experience, confident, alert, analytical, courage, compassion, more than the listening part. We should understand the background of the trainee and what he wants and how we can incorporate. We should be really compassionate about them because he has come to learn all the way from far off place, spending his time, spending his money, and he has come us to learn, and we should have the responsibility of teaching. This basic thing should be necessary in a trainer. And the trainee, he should be humble, responsible, patient, well-read, practice, well said. But how do we incorporate a person from a different background? It is the culture of the organization. If you really see, like what Dr. Selvam about, professionalism, if you really care about the patient and all your whole system is geared towards that, then the person understands this is a serious business. We are not just because he has paid some money, he cannot take things for granted. So that has to be insisted. And the patient concern. Yes, the patient wants, and we also want safety and good outcome. One more thing is the table time. Patient always look at the quality, the amount of time that he spends on the table. So we have to be really careful. And for a trainee, it takes a longer time. Understood. So what we have learned over a period is how to reduce the table time. So my height and my trainee height are different. So we have two different stools of different height. The table, microscope height are standardized. So what we do is we have one person shifting because it is very difficult to control the surgery through the monitor. So we have to look through the microscope. The side microscope is not very comfortable. So we do that. And only few steps a day. 30 cases assured, 4 days surgery. So you are assured one step you finish, you move to the next step. So day 1, we know what we are going to teach. Day 5, we know what we are going to do. So at the end of day 9 or 10, he should be in a position to fully do the surgery. This is how. And no discussion during surgery. It's always afterwards. So you reduce the time. And only instructions, especially monosyllables. Do, stop, come out, enough, give more power. So order. It is only what I say. On the table, in that level, it is me who is dictating, you do it. Don't stop arguing. Only selection. Last month he has finished DNB. A lot of recommendation, take me for surgery. No. Minimum 3 years. They should go back and also see where they are coming from, where they are going to go back. If they are going to go back and do surgery only, we take up. Because my time is also precious, my patient's vision is also precious. And they should be in a position to understand the pain of the patient. This is very important. So challenges, complications, managing those complications, lot of cost involved in setting up a program, and the case availability, or a medico-legal aspect, and finally, the reputation of the institution. These are all very important. Rewards. That is self-improvement. The more you teach, the better you become. And the institution is built on that reputation. And there is a recognition. Finally, above all, it's a satisfaction. So this is what we get. Finally, what gives me more pleasure is a satisfied patient. Thank you.
Thank you so much, sir, for that presentation. I had a question for a lot of studies that we do, presentations in the journals. We have a medical review committee, so on and so forth, ethics committee. When the patient is getting operated in your institution, do you take a consent from the patient that the student will be operating on your patient and we will be actually teaching him during the surgery?
No, sir.
is that what is the views of the House of whether that is legal or illegal or it's okay?
We don't do that also.
No, I don't think that is the issue.
When we have that is an issue. When
no,
you
no.
are doing
It's
so
not-
much
it's not
ethics
like-
committee is there for an article. When you are operating on a human being, we don't tell that somebody is going to learn on you.
Good question. Yeah.
No, but see, basically in Indian setup, it's an assumed consent. It's a presumed consent, whatever. So here probably the people who have done the post graduation are getting trained. They are equipped with the thing.
Sir,
to
my
practice.
question is whether the patient knows or
where
not.
is the learning?
The
Even I
patient
am a
has given
learner
a
too.
consent.
Even I am a learner today. Even today also I am a learning cataract surgery. So there's nothing like a learner and somebody who has learnt. So
But the patient has come to Joshi Eye Hospital thinking that all are learned here.
No. The point is learning never stops in that case. Here there's a postgraduate who has already finished postgraduate and come for a further training. He is legally having an MS degree or DNB degree.
Sir, consent from the patient. That is the question.
No, I don't think.
Do you
consent is
tell the
taken
patient
anywhere.
that the
No, we
person who is going to operate on you
nobody-
is
Nobody
going
will
to
get
learn?
operated.
Nobody tells.
Nobody will
Is
get
that legal or illegal?
No, we are not sure whether it's illegal. Nobody knows the question, answer for that.
No, more than legality, whether it's
Trainer
ethical.
and the trainer.
Why
both.
ethical? I can rephrase my question. Whether it's ethical or not ethical.
No.
Yeah, so-
Legally, from legal aspect, absolutely a person who's postgraduate, doesn't matter, he can be 50 years of experience or 30 years experience. He can be very bad in surgery. There are so many surgeons who have learned, finished PT.
But
and
he can
done.
operate.
But he can legally,
legally-
at least
legally he can operate.
As a
he can
patient, was I to be informed or not that he
As
has
of
done
now, there
only
is no
one cataract
legal-
surgery
yeah.
and is next he is going to operate on my eye?
As of now, legally, there is no that it has to be compulsory told to the patient that you are being learnt on your eye. There is not that, definitely.
We have so
legally.
many policies to write an article in the Indian Journal of Ophthalmology.
Right,
So
sir.
many ethics committee, this committee, that committee. But for surgery, we don't take the consent of the
No,
patient.
but what he's saying is they have the surgeon's name written and the other surgeons who is assisting his
Both
name
the
is written.
surgeons.
Both the
The
surgeon name
training
is
and what-
so that
what-
is, I think, more
But
than
the
sufficient.
assistant is
we do-
actually the operating
Satyajit,
surgeon.
What we do is we ask the trainees to talk to the patient before the surgery. All the patients
And
are
tell him that I'm going to operate and I don't have experience.
Tell the name of to the, but not the experience and all that. But tell the patient that he's going to operate on it. So such and such a person is going to operate with the name, everything. So to the patient we tell them.
I think this is a bit difficult question to answer, definitely a tricky situation. But I think legally you are right, if someone has an MS or MD degree, he can do that. But the question is, before you have achieved the MS or MS degree, you need to train them at that point of time also, and then legally you are not covered. So I think...
Legally it's not a problem, sir. You're not asking an optometrist or a technician to operate.
No, they are
You are asking
every-
only a
You have not
postgraduate.
taken the consent of the patient.
No.
Yes.
The consent of the patient, that's what, the oral consent is given. Not the
No,
written
consent of
That
the
a second
patient.
year postgraduate will be
the-
operating on
the the trainee in our setup, I'm sure PANNEER is also doing that. See, please, for the information of everybody, PANNEER SELVAM has got one of the most popular phaco training programs in the entire country.
This question is not only for him.
No,
it's
no,
for
I'm just telling you.
everybody.
I'm telling you,
even
I
abroad-
ask all the trainees to talk to the patients, mention the name of the doctor to the patient. And suddenly I'll go and random check. I'll ask the patient who's going to operate on you. If the patient does not say the name of the doctor, I will not give the surgery to the patient, to the doctor.
I think
basically-
Dr. Sushmita was saying, like Royal College will have to have a what do you call that?
So actually, even abroad,
In
sir,
place.
what they say is there is a primary doctor, then there are assistants. So assistants come under trainees. Eventually, they are the ones who are learning from the primary doctor or helping the primary doctor to complete the case. So even in abroad also, if they are being trained or the student, the doctor doesn't go to the patient saying that your eye is going to be the source of my learning, I'm going to do it, and then they start. Absolutely not.
Is that ethical?
I think there also
Definitely,
a,
Doesn't the patient have the right to know?
no, there is also a
Yes, ma'am.
there is also a separation between the private run hospitals and the public run hospitals in abroad. Because if you're going to a public hospital and the consultant who sees you, he is understood that he has trainees with him. But in a private, you are going to a specific doctor and you want to be operated by him. So I think that issue would
And
still
what
be- I
about
don't know
the
how
foreign
you
trainees?
deal with that. Yeah.
Correct.
We
Yeah,
get
so
the
I-
permission from the medical council.
Yeah.
And properly, and we take them any
Medical council,
medical
yes.
legal problem, it is the trainer who is responsible.
Yes.
And we
It's
give an
written there,
undertaking to
yes.
that. So it is a proper rule.
I did, I did fellowship in the University of Iowa and we did hands-on training. So a patient would off and on ask Dr. Scott, my mentor, will you be doing the surgery? He would always say, I and my team.
Yeah.
Okay, because that is the truth. If you, the patient, you cannot tell every patient my training is going to be doing. It is implied when you come to a teaching hospital that the trainee will participate in the surgery. We don't know what percentage, but they will participate. Never in private practice, when you're in private practice, you never let, that usually no trainees in private practice, I'm talking of the US, it's always in university hospitals. So the answer is, it is implied, one. Number two, they always would say it's my team. So, which includes the training.
So
And many a time, the patient himself will know, are you teaching on my eye? So that is why we always take it care that less discussion, monosyllables, just instruction, all these things are done just to, otherwise he will lose confidence. And the table time is very important only because, not that we are hiding something, but the patient's confidence should not be lost. This is the only reason.
Virender sir?
And anything is responsibility of the institution.
Yeah, actually, that is very correct, because when I was in Moorfields, I asked them the first day that why do you operate all patients under GA? They said because it's a training hospital. That is the reason we operate under GA. All patients, everything, even a Calazian is done under GA.
Caladian under GA?
No, just the patient should not know and should not lose confidence. But my question from you is that what about PGs? This is not about
वो हम सब समझ गए. What is being done is correct. तो नहीं होगा तो teaching कैसे होगा? वो तो हम समझ गए. But is it ethical that the patient does not know that my eye is being operated by a trainee? That is my question. The system is correct. उसमें कोई दिक्कत नहीं है.
I think ideally they should know it. I mean, they have
Yes,
the right, they have the right to know it. So ideally they should know it. But how you put it, that's the question.